In this video, we will discuss about the different types of arrhythmias. It's broadly classified into two types. One is atrial arrhythmias and one is ventricular arrhythmias. So atrial arrhythmias are those which basically originate from atria, and ventricular arrhythmias are those which originate from ventricles. Okay, so in the atrial arrhythmias, we can call them as supraventricular arrhythmias. So what does this mean? Supra means above, right? Supra means above and ventricular means ventricles. So the arrhythmias which originate above ventricles, okay, so above this point, whatever the arrhythmias are originating, those are supraventricular. These supraventricular arrhythmias are basically classified into 5 different types. Okay, so one is AVNRT, another is AVRT, another is atrial tachycardia. It can be single focus or multifocal atrial tachycardia. Another one is atrial fibrillation and another one is atrial flutter. So we have 5 different types. Based on the names of these arrhythmias, I'll give you guys a brief idea and we'll discuss in detail about these arrhythmias in a bit. Okay, so let's see about this AVNRT. So what is AVNRT? AV node reentrant tachycardia. Okay, so there is re-entry from AV node, okay, and this causes the tachycardia. So you have the AV node over here and there's re-entry of electric current through this AV node into the atria, which is causing an abnormal rhythm. Okay, so this is AV nodal reentrant tachycardia. The second one we are going to discuss is AVRT, that is atrioventricular reentrant tachycardia. It is also called as Wolff-Parkinson-White syndrome. Okay, so what does this mean? So basically the electric current goes from atria and ventricle and then it re-enters. Okay, so it's going from atria, it's going down to the ventricles and then it is re-entering the atria. This is AVRT. Okay, it is due to the presence of an accessory pathway. Okay, next is atrial tachycardia, single focus. It's because of a different electrical pacemaker which is present in atria. Other than the normal AV node, there's another pacemaker in the atria which is causing abnormal conduction. Okay, then comes atrial fibrillation. We have fibrillary waves over here like this, and then comes atrial flutter. We have flutter waves over here. Okay, so let's look at the origin of these. So if you look at the origin, AV nodal reentrant tachycardia, origin is AV node because there's re-entry from AV node. Okay, next we had the AVRT, that is accessory path. Because of the accessory path, bundle of Kent, here is the bundle of Kent, right? There's re-entry, so accessory pathway. Third is due to ectopic pacemaker. This is atrial tachycardia. Atrial fibrillation and atrial flutter are very important because they ask this multiple times. So atrial fibrillation, the origin is pulmonary vein. So we have the pulmonary veins over here, and these pulmonary veins are passing on an abnormal electric current which is causing the fibrillary waves. Okay, and here is the cavo-tricuspid isthmus. This is near the opening of inferior vena cava. Okay, so this is cavo-tricuspid isthmus. This is causing atrial flutter. Okay, since we have briefly discussed about the 5 different supraventricular arrhythmias, let's talk about the general ECG changes which we can see in the supraventricular arrhythmias. So ECG consists of P, QRS and T waves, correct? This is a proper ECG thing. So what does P mean? P means there is atrial depolarization. QRS means there is ventricular depolarization. And T means there is ventricular repolarization. So what is happening in supraventricular arrhythmias is there is a problem in atrial depolarization. So there is a problem in the P wave, correct? And then there is followed by a narrow QRS complex and T wave is present. Okay, there's no inversion, no hyperacute or no flat T waves, just normal T waves. So there is a problem in depolarization followed by a narrow QRS. When there is a problem in the ventricular depolarization, the QRS becomes broad. Okay, so that's why the supraventricular arrhythmias have narrow QRS, not a broad complex but narrow QRS. So you have problem in atrial depolarization. For this reason, you can see the P waves are buried in the QRS complex, or you have retrograde P waves. What are retrograde P waves? They are spikes at the beginning or at the end of QRS complex. So these are at the beginning, pseudo R waves, and there's pseudo P wave, okay, at the end. Let's talk in detail about the different types of arrhythmia. The supraventricular arrhythmias, as you can see, the P waves are not regular, that is they are either buried, or you have retrograde P waves, that is at the start or end of QRS complex, and the QRS complex is narrow. And if you talk about T wave is present. So let's discuss in detail about the AVNRT. So what did we say about AVNRT? AVNRT was basically AV node reentrant tachycardia. What does this mean? AV node reentrant tachycardia means there's a problem in the AV node due to which there is re-entry of electrical current. Okay, there are two requirements for this. So the first one is there should be dual pathways. Second is it is triggered by PAC, premature atrial complex. So what is dual pathway, if you ask us? It is only present in some people, okay? It's not present in all. So basically the AV node has two pathways. One is fast pathway and one is slow pathway. So usually electrical current passes down the fast pathway and then it goes and supplies the ventricles, okay, and the slow pathway slowly keeps coming here, and after supplying the ventricles it goes and cancels out the slow pathway current. So what happens is when there is a premature atrial complex, okay, so when the fast pathway is in refractory period, okay, it has supplied, it has cancelled and everything is done, now it's in refractory period waiting for the next impulse. So before this happens there's a premature atrial complex which goes down the slow pathway, okay, so it has come down the slow pathway and it goes and enters the fast pathway. Now from the fast pathway it goes and supplies the atria, and this leads to abnormal rhythm. So when it goes to the atria it produces retrograde conduction. For this reason you have buried P wave. So let's talk about P waves, QRS, RR interval. So P wave is buried, QRS is narrow, and RR interval is regular over here. Now let's talk about the AVRT. AVRT is accessory pathway between atria and ventricle, that is bundle of Kent, right? We discussed there is bundle of Kent. We discussed the AV node supplies the atria and ventricle, and due to the bundle of Kent over here, there's resupply into the atria, that is re-entry into the atria. This is AVRT. Sometimes it is a characteristic of Wolff-Parkinson-White syndrome. So in Wolff-Parkinson-White syndrome there are three subtypes. So one of the subtypes is AVRT, AV re-entry tachycardia. If you talk about the P, QRS and RR, so you have retrograde P wave, QRS is narrow and RR is regular. You can see for AVNRT you should have a dual pathway and it should be triggered by a PAC. So regular RR, buried P wave and narrow QRS. These are the characteristic features. And if you see here there's QRS and T, you can't see any P waves here. It's showing you how the P waves are buried over here, inverted P wave. In AVNRT we have discussed it is usually triggered by PAC or PVC, characteristic arrhythmia of WPW syndrome, retrograde P wave, narrow QRS, RR interval. These are the retrograde P waves. So these are the things you should remember about the AVNRT and AVRT. We'll discuss about the PAC and PVC in a bit, and about the management of these AVNRT and AVRT. So you should check for the hemodynamic stability first. If the patient is unstable, you should go for cardioversion. What is cardioversion? Cardioversion is basically when you give shock in sync with QRS complex. So it's called synchronized cardioversion. Next, if he is stable. So when he is stable, you should go with vagal maneuvers. So what are vagal maneuvers? One of them is Valsalva. What is Valsalva? Straining. Okay. Next comes carotid massage. Next is diving reflex. So these increase the parasympathetic tone, which decreases the AV conduction, AV node conduction. After vagal maneuvers, IV adenosine can be given. This is very important. When you have given IV adenosine, in the next step, what can you give? Means you can give rate and rhythm control drugs, that is beta blocker, calcium channel blocker, and if the patient is in heart failure, you can give them digoxin in heart failure with reduced ejection fraction. These are the things you can do. When the patient is unstable, go for cardioversion. Cardioversion is synchronized shock. And if the patient is stable, you go with vagal maneuvers, that is Valsalva, carotid massage, and diving reflex. Since we have discussed the first two, paroxysmal supraventricular arrhythmias, that is AVNRT and AVRT, let's discuss the third one, that is atrial tachycardia. It can be single focus or multifocus. So what happens here is, the normal electrical conduction of heart is sinoatrial node, which passes conduction to AV node. Now this AV node will deliver the conduction to the ventricles via a bundle of his Purkinje fiber. What happens is, besides the sinoatrial node, there's another ectopic pacemaker. This can be single focus or they can be multifocus tachycardia. Let's talk about the multifocal atrial tachycardia. The origin is basically ectopic pacemaker. Besides sinoatrial node, there's another pacemaker which is causing this. Let's see at the P, QRS and RR intervals. P wave, you have multiple morphologies because it is multifocal atrial tachycardia. Why multiple P morphologies? Because there is multiple focus in the atria. That's why there is multiple depolarization signals, and hence you have multiple P morphologies, that is more than 3. QRS is normal because obviously this is supraventricular arrhythmias. Then RR is irregular. This is important. RR is irregular. If you look at the ECG here, you have ectopic focus driven by acute illness, most commonly in COPD exacerbation. These two are the very important points. These occur mostly in elderly patients. Okay, elderly patient and COPD are the two keywords you should remember about this arrhythmia. Okay, and if you see here, you have multiple P wave morphologies, right? And the RR intervals are irregular. As we just discussed, the pathophysiology is basically an elderly patient and he should have an underlying pulmonary disease. These are the two clues which the history gives. Now let's talk about the triggers of this condition. What are the triggers which are causing multifocal atrial tachycardia? The first trigger is right atrial enlargement. When the atria gets enlarged, it initiates multiple foci which can generate electrical conduction. Another one is electrolyte imbalance. The third one is catecholamine surge. This occurs during sepsis. How do you manage this condition? So initially, when there are any triggers, for example, right atrial enlargement or electrolyte imbalance or sepsis, you need to correct these three things. If there's a sepsis, treat the cause. If there's electrolyte imbalance, then give them that electrolyte. If there is right atrial enlargement, identify the cause of enlargement, why the atria is enlarged, and then treat the condition if possible. Okay, so first is trigger control. And obviously, since most of the time it is due to underlying pulmonary disease which is causing right atrial enlargement, correct? So you need to give bronchodilators because there's an underlying disease most of the time. Another thing you can do for the pulmonary disease is supportive oxygen and ventilatory support. Last thing is systemic steroids. So this is how you manage a multifocal atrial tachycardia. First thing is control the trigger. Since most of the time it is due to underlying condition, give them oxygen, ventilatory support and bronchodilators. And last thing is systemic steroids. This is all you have to know about the multifocal atrial tachycardias. We are left with two of them, okay? And these two are the main supraventricular arrhythmias you should and you have to remember by heart. So the first one is AFib, and it is one of the most important arrhythmias that you have to remember. As we have discussed that the origin is pulmonary veins. The abnormal conduction starts from pulmonary vein. If we see about the P and QRS and RR intervals, P waves are absent. This is one of the most important points that you have to remember. P waves are absent only in a few rhythms, and atrial fibrillation is the most important one. P waves are absent over here, and RR interval is irregular over here. And QRS complex will be obviously narrow complex. Now let's talk about the effects of atrial fibrillation. Let's see what happens here. What is P wave? P wave is atrial depolarization, correct? So during atrial depolarization, atria contracts. And here we can see P waves are absent. So when the P waves are absent, that means there is no atrial contraction. What happens when there is no atrial contraction? No atrial contraction means there is decreased preload. That is atria to ventricle. Very little amount of blood goes into the ventricles. Okay. And since it's not contracting, the atrias are not contracting, there is blood stasis. This blood stasis can lead to embolism. And if this is left untreated, it will cause tachycardia-induced cardiomyopathy. So these are the most important effects you have to remember about atrial fibrillation. And if you see the types of atrial fibrillation, there are 3 types of atrial fibrillation. First one is paroxysmal. Second one is persistent. And third one is permanent. What does these terms mean? Paroxysmal, that means it comes and goes. It doesn't stay for days or weeks. It just comes for a few minutes or hours and then it goes away. Okay. Next is persistent. It stays for days to weeks. And now permanent is can't reverse this rhythm. What should we do to manage this? Paroxysmal comes and goes, so we shouldn't do any management unless the patient is hemodynamically unstable. Okay. Next, persistent. How should we manage it? Days to week. This requires cardioversion. And permanent. That means can't reverse to sinus even after cardioversion. Okay. So these are the 3 types of atrial fibrillation that you have to remember. Let's look at this ECG of atrial fibrillation. So you have here 1, 2, 3. So 2.5 large box here. And you just have 2 large boxes. Similarly 2, then 2.5. That means there is no regular RR interval. That means this is irregular rhythm. And you cannot see any P waves, right? Here you have fibrillatory waves. This is atrial fibrillation. Now let's see how to manage atrial fibrillation. Management is, you should see if he is hemodynamically stable. If he is stable, you should do rate, rhythm, control and anticoagulation. And he is not hemodynamically stable, you have to perform cardioversion. So how do you control the rate? It is beta blocker, calcium channel blocker, and if the patient is heart failure patient, then digoxin. If still this doesn't work, then you can go for amiodarone and ablation. How do you control rhythm? With cardioversion. And you have to give an anticoagulant, aspirin or warfarin. And the goal INR should be between 2 to 3. So cardioversion can be 2 types, electrical and chemical. Electrical is basically sinking and giving a shock. Sinking with QRS and give a shock. Chemical is give ibutyl. So this is how you manage an atrial fibrillation patient. If he is unstable, go for cardioversion. If he is stable, then rate, rhythm and anticoagulation. Anticoagulate the patient with aspirin or warfarin. Do the rate control, beta blocker, calcium channel blocker, digoxin. Still not controlled, amiodarone and ablation. Ablation where? Here, near the pulmonary vein. This is the point where you do the ablation. Next is rhythm, cardioversion, electrical or chemical. Electrical is synchronized shock with QRS, chemical is ibutyl. Now let's discuss a bit further about the conditions that are associated with atrial fibrillation. So hypertension, coronary heart disease, rheumatic or valvular heart disease, congestive heart failure, HOCM, congenital heart disease, post-cardiac surgery. Now let's give a little logic to these cardiac causes. As you know, rheumatic or valvular heart disease like MS and MR, because of the excess pressure and excess volume of blood here in the left atria, you have loss of atrial contraction. Correct? This will cause atrial fibrillation, which will lead to embolisms. Similarly, congestive heart failure, heart is tired, it cannot pump. Hypertrophic cardiomyopathy, here also there's too much of pressure in the ventricle, which is pushed back to the atria. This will lead to loss of contraction of atria. Congenital heart diseases like atrial septal defect, these also volume overload causes atrial fibrillation. Okay, post-cardiac surgery. Next comes pulmonary causes. Obstructive sleep apnea. This atrial remodeling. What do you mean by atrial remodeling over here? Due to the constant hypoventilation, there is pulmonary vasoconstriction. Okay, this will lead to pulmonary artery hypertension. This pulmonary artery hypertension will cause right atrial dilation. Pulmonary embolism, COPD, acute hypoxia. Next comes obesity, hyperthyroidism, diabetes, alcohol abuse, drugs like amphetamine, cocaine, and theophylline. So the causes and conditions of atrial fibrillation are very important. They might ask several questions regarding this. So hypertension is the most common. Miscellaneous may you have obesity, alcohol, diabetes, hyperthyroid, drugs like cocaine, amphetamines, comorbidities that encourage atrial fibrillation. So age and hypertension. Top one that precipitates atrial fibrillation is hypertension. It is a must remember thing. You have to know about it. So if they give like multiple comorbidities in a question and they ask which one has precipitated the atrial fibrillation, then your answer has to be hypertension if it is present in the comorbidities. Okay, if they gave both age and hypertension, the answer is hypertension, because hypertension is the most important comorbidity that can encourage atrial fibrillation. Okay, in addition to that, LV failure, mitral valve dysfunction, anything which causes the left atria or right atria to expand due to volume or pressure overload, that causes atrial fibrillation. Coronary artery disease, diabetes, smoking, obesity, obstructive sleep apnea, COPD, hyperthyroid. Now let's talk about the triggers that increase automaticity. Hyperthyroidism, alcohol use, increased sympathetic tone like acute illness, sepsis, PE, MI, cardiac surgery, sympathomimetic drugs like cocaine. So they might give you a question like a patient went for binge drinking and now he came to the ER and stuff like that, and you can see atrial fibrillation on his ECG. So that atrial fibrillation might be caused due to excessive alcohol use, that is binge drinking. Okay, so hyperthyroidism, alcohol use, and acute illness or cardiac surgery might cause the trigger of atrial fibrillation. Okay, so you have to know that triggers can cause atrial fibrillation even if there are no risk factors. Okay, so these were your risk factors which were causing atrial fibrillation. Even in the absence of these risk factors, these are the triggers that can cause atrial fibrillation. So if you stop the trigger, there will be no further atrial fibrillation. Okay, if the risk factor is present and you have this trigger, okay, risk factor and trigger both are present, that means there is an increased risk for recurrent atrial fibrillation. Okay, so if this is not present but this is present, if you stop this, it will work. If both of these are present and if you stop it and hope that there's no further chance of any more episodes, then you're wrong. There is an increased risk if both of it are present. Okay, next important thing you have to know about is CHADVAS score. CHADVAS. So C is congestive heart failure, hypertension, age, diabetes, stroke, vascular disease, again age, and this 6, that is females, it's more common. Age more than 75, 65 to 74. If the score is more than or equal to 2, that means there's a high risk for stroke. So you have to put these patients on anticoagulants. One more thing you have to know is how do you manage a new onset atrial fibrillation. So you have to check if the patient is stable or unstable. As we all know, unstable patient should undergo cardioversion. Unstable person should undergo echo and TSH levels. After that, you can do rate, rhythm, and anticoagulation. Let's discuss the last one of the lot, that is atrial flutter. The origin is from cavo-tricuspid isthmus of right atrium. Okay, this is very important. What about the P wave, QRS, and RR interval? RR interval is regular, QRS is narrow, and P waves are sawtooth flutter waves. Okay, and risk factor is same as AFib, and management is also same as AFib, that is rate rhythm control should be done, and ablation. So where do you do the ablation? The area where inferior vena cava opens into the right atrium and where you have the tricuspid valve annulus. Okay, so here is the annulus, correct? Open. So this is the area where you will find the cavo-tricuspid isthmus, and you have to ablate here for atrial flutter. And where do you have to ablate in atrial fibrillation? Near the pulmonary veins. This is called left atrial appendage. So they can give you both the terms left atrial appendage or pulmonary veins, and here you have to ablate in the cavo-tricuspid isthmus, that is area between the inferior vena cava and tricuspid annulus. So this is how you manage atrial flutter. So if you see the ECGs, you have the RR intervals may or may not be regular or irregular. Okay, so you have the flutter waves here. Okay, sawtooth flutter waves. RR is irregular. यहाँ पे you have cavo-tricuspid isthmus. Risk factors are similar. Sawtooth flutter, and ventricular response rate is constant or variable. That's all you have to remember about the atrial. Since we have completed the atrial flutter and all these 5 different supraventricular arrhythmias, there's one more topic I want to discuss, that is about the PAC, PVC and Wolff-Parkinson-White syndrome. Let's discuss about the PAC and PVC. So if you talk about PACs, the name is premature atrial complex. So from the name itself, we know that the atrial complex comes early, right? So if you look at the PQRS T waves, so this is what you look in the ECG, correct? So you have an abnormal P wave because the atria becomes abnormal. There's a premature conduction, okay? So you have abnormal P waves, and QRS will be narrow complex, right? Because the ventricular depolarization will occur as it usually occurs, followed by a normal T wave. Okay, what about premature ventricular complex? So here P waves are absent. QRS complex will be wide complex because there is a problem in the depolarization of ventricles. You will have a broad complex Q, and then T waves may be inverted. So everything is abnormal in ventricular complex. Okay, so both of these PAC and PVC are followed by a compensatory pause. There's an abnormal P wave here, QRST, and there's pause. When you look at PVC, there's an abnormal wide QRS and there's a pause. There's no P wave and you have inverted T wave, right? QRS and inverted T, there's a pause, there's no P wave. This is PVC. Now let's talk about the Wolff-Parkinson-White syndrome. So Wolff-Parkinson-White syndrome is an accessory conduction pathway which causes the re-entry of the electrical current into the atria, and this causes abnormal rhythm. Okay, and then there's ventricular pre-excitation, that is, it gets excited prematurely. Here is a re-entrant circuit, here is an accessory pathway which causes a pre-excitation. Okay, so if you look at the WPW pattern, you'll see the P interval, that is from the start of P to end of QRS, right? So this will become short, and you'll see QRS will become wide, and you can see a delta wave. So if you look at it with a logic, everything becomes clear. Okay, because of the pre-excitation, there's an upward slope, correct? This is called delta wave. Now because there's a slope, the QRS has become broad, right? And you can see the PR segment has also shortened. So if you look at it logically, all of the 3 things can come together. You have short, you have delta wave, and you have wide QRS. The 3 things of Wolff-Parkinson-White syndrome ka pre-ECG. There's short PR, wide QRS, and delta wave. So as you can see, there are 3 patterns. One is re-entrant tachycardia, one is pre-excited atrial fibrillation. So what is happening here is there's an accessory pathway which is causing pre-excitation of ventricles, okay? And there is sinus rhythm where you have like the normal, this rhythm. Okay, you have short PR, you have delta waves, you have wide QRS, that is the sinus rhythm. Okay, so if you see delta wave is present, it is dependent on AV node, there's no need for treatment. AVRT means there's no delta wave because there's a re-entrant circuit, right? The complex width is narrow, okay, narrow complex is there, and it is dependent on AV node. Yes, because the current flows from AV node and then goes to ventricle and then re-enters atria. That's why it is dependent on AV node. Pre-excited atrial fibrillation is not dependent on AV node, it is dependent on accessory pathway. So AVRT, the treatment are vagal maneuvers and adenosine. If this doesn't work, you go for amiodarone. Pre-excited atrial fibrillation, you go with procainamide. See pre-excited atrial fibrillation here. You have delta waves, wide QRS complex, and you have irregular rhythm over here.